One more speaker. I want to introduce Dr. Samantha Wong, who's joining us from the University of Washington. I was going to make a quip about we should all be unbiased according to where we did our training and
Those people.
all right, Dr. Wong.
Yeah. Hi, everyone. My name is Samantha. I'm a PGY2 in internal medicine at UW. I'm here to present a case that I saw when I was on Hemonc consult called TB not to be, identifying a cause for HLH in a patient with lymphadenopathy and a positive AFB smear. And we'll discuss the case, the diagnostic workup, and the final diagnosis with some learning pearls at the very end. So the case begins with a 77-year-old Cambodian-speaking woman. She was admitted to heart review for hypoxia, increased confusion, lymphadenopathy, and 2 weeks of fevers, chills, and night sweats. She previously had been admitted to an outside hospital and discharged the week prior. There she was found to have pancytopenia, which was concerning for malignancy versus extrapulmonary TB. And ultimately she was discharged with an outpatient IR referral for a lymph node biopsy. But since she had been feeling worse, she came back to the ED at heart review. For her social history, she moved from Cambodia to the US in 2004. Her husband had a history of treated pulmonary TB, and at the community hospital, she was found to have a positive quantiferin gold, but negative sputum to blood smears and negative PCR. In the ED, she had an initial oxygen saturation of 80% and was put on 2 liters nasal cannula with improvement to 91%. Her heart rate was 92, and she was 108/89. She was pre-tachypnic to 22 breaths per minute. Per her family, she was more confused than normal. And her exam was notable for crackles, but and otherwise her cardiac exam was normal. They did get a CT abdomen in the ED, which is shown here, with pretty remarkable splenomegaly, as well as CTA chest to rule out PE. She was negative for PE, but she did have some non-specific left supraclavicular spinal lymphadenopathy again. So she ended up being admitted to medicine for further workup. So obtained and some specialists consulted. As you can see here, she had a pancytopenia and was transfused for this. Other abnormalities included this low absolute reticulocyte count, a high LDH, and a high ferritin but a low iron. As we discussed, her positive quantiferin was further explored, and she had 4+ AFB on her speed smear on mission. And so we also obtained a Gen Expert PCR assay to rule out tuberculosis, which is generally 95% positive and smear positive TB, and that was negative. So further AFB cultures were sent. At this point, many consultants were brought on board. Infectious disease thought this was possibly TB, and so put on airborne precautions and asked to wait for the AFB culture results. IR was consulted for a core biopsy of this lymph node, and Hemonc was consulted for this pancytopenia, which initially we thought was related to disseminated TB. Unfortunately, 5 days after admission, she began to be more febrile and tachypnic and had intermittent hypotension, and multiple rapid responses were called. This was controlled with Tylenol, control, and supplemental oxygen. But because of this, the ID team decided to start her on empiric TB treatment with RIPE therapy and azithromycin. And I went ahead and got that core biopsy of the lymph node. Pathology at that point was still pending. Then we got a call that the peripheral flow cytometry that she obtained at the outside hospital was revised to show an abnormal mature B cell population. At this point, this is 11 days since admission, and her ferritin is now 1,095. And so again, ID recommended continued RIPE and azithromycin. Unfortunately, the lymph node biopsy was inconclusive. And because of all this diagnostic uncertainty, Hemonc decided to go ahead and get a bone marrow biopsy. 17 days after admission, she was transferred to the MICU. She was emergently intubated on the floor. Her ferritin was now 22,000. And so I think these factors highlight a very crucial diagnosis, which is HLH. HLH, or hemophagocytic lymphohistiocytosis, is a syndrome of uncontrolled multifactorial inflammation that causes multi-organ failure and death. And this figure from the New England Journal of Medicine threshold theory suggests that causes of endogenous and exogenous inflammation can come together, including infection and malignancy. This patient already met 4 out of 8 criteria for HLH, but fibrinogen and triglycerides have not been evaluated. This eventually came back, cementing the diagnosis of secondary HLH with triglycerides at 275 and SiO2RA at 17,645. Typically, HLH can be treated with steroids, but this was deferred given that there was concern that this would decrease diagnostic yield of further biopsies. The morning of her transfer to ICU, her biopsy came back, resulting in stage 4 diffuse large B-cell lymphoma. She was quickly started on chemotherapy, and her sputum culture also found a species of mycobacterium, which is typically a colonizer and not a source of lung disease. Unfortunately, she was started on chemotherapy quite rapidly. Her course progressed with renal failure, multiple strokes, and she was put on comfort care. I think ultimately from this case, I really that the treatment of secondary HLH is ultimately treating the underlying cause, which is difficult when you have so much diagnostic uncertainty about the underlying cause. Especially in this case, it took weeks for the cultures to result. And lymphoma-associated HLH is rare, but has a particularly poor prognosis of about 2 months compared to other non-malignancy causes of HLH. And I think above all, our team reflected on the importance of avoiding anchoring biases. She came in with this story that I think we all are thinking is disseminated TB. But when patients are getting sicker and sicker, I think it's very crucial to think about what else might be driving the sickness. These are my research references. Thank you for your time. I'm happy to take any questions. Yes. Yeah, I think something that pieced together until we looked back. Sorry, and the question was, what was some takeaways that we could get from this case to see how we could diagnose HLH sooner in this patient? I think in this particular case, looking back, the kind of like through point through all of it was her rising ferritin. I think it's very difficult because people will come in with anemia of chronic disease all the time. But in this case, when you're kind of grasping at straws as to really finding a clear diagnosis for this patient, I think trending that ferritin ultimately was what helped us make that diagnosis. Yes, in the back.
In your research, did you determine how often somebody would have disseminated TB after being in this country for over 20 years and never having had it seen?
Yeah, so the question was how often do people get disseminated TB after being in this country and for over 20 years and never having had TB before? That's a great question. I believe that I didn't include it in the case, but this patient did travel back and forth to Cambodia. And so I think just given that and that we had this like quantiferon that was positive, there was just a non-zero chance that this could have been disseminated TB. Great, thank you so much.